Okay, so there we go. We're recording right now. Just a quick reminder to please mute your phone or computer if you're not speaking. I want to keep the lines open and active so that we can have comments. You're welcome to use the chat box as well. So welcome. This is a really kind of a more first pediatric medical recognition community of practice call. And we really wanted to welcome, we've had a couple calls, which I'll go to in a second, bit with the participants in the Facility Recognition Collaborative, but now we have opened it up to all states working on this performance measure. And really want to welcome you. We're going to give you some background, bring Audrey up to speed. We'll hear from two of our states, from Tom Martin and from Margot in Connecticut and Indiana, talking about their medical recognition programs. And then in the end, I'll finish up by showing you some of the resources that are available to you all and getting your opinion on how we can make that better and more useful for everyone working on this. So let me begin with our acknowledgement and disclaimer. We're supported by HRSA of the U.S. Department of Health and Human Services under the following grant numbers. The information, our content, and conclusions are those of us and should not be construed as the official position, policy of, nor should any endorsements be inferred by HRSA, HHS, or the U.S. government. As I stated, there's our agenda for the call today. I'll briefly review kind of the current state of the pediatric medical recognition programs around the nation. And then Kate Remick will jump in with some background on pediatric medical recognition programs, including a brief history of the Facility Recognition Collaborative, briefly highlight some of the recent community practice activities, and we'll hear from Indiana and Connecticut and then go through the available resources. So we'll begin by just kind of reviewing the goal of kind of why we're all here, besides the obvious improving pediatric medical care across the nation, but that really is its performance measure 4. And that is by 2022, 25% of hospitals are recognized as part of a statewide, territorial, or regional standardization program that are able to stabilize and or manage pediatric medical emergencies. And so that's the end goal. Presently, and this is data from HRSA, we have 15 states with pediatric facility recognition programs, with established programs. And that would be Alaska, Arizona, California, Connecticut, Delaware, Illinois, Kentucky, Montana, New Jersey, New Mexico, Ohio, South Carolina, Tennessee, Utah, and West Virginia. And that is the recognition criteria is based on the 2018 Pediatric Readiness and Emergency Department guidelines. Most of these programs are voluntary, and the host institution varies. So when we say that they have an established program, what do we mean? And that means that they're in phase 5. And so this is the general phases. As you can see here at the top, phase 5 is our 15 states with recognized programs. However, the majority are in phases 0 and 1. And how do we define these phases? And that is 0 is no progress has been made toward developing a program. 2, and I like to think of it as we're thinking about it. So research has been conducted on the effectiveness of a pediatric medical facility recognition program, and or developing a pediatric medical facility recognition program has been discussed by the EMSC Advisory Committee, and members are working on the issue. Now, number 2 is that the criteria has been developed. So criteria that the facilities must meet in order to receive recognition has been developed. Phase 3 is that an implementation process or plan for this pediatric medical facility recognition program has been developed. 4, the implementation process plan has been piloted, and 5, at least one facility has been formally recognized. So this is kind of the breakdown, and you can see on the right-hand side, similar to the bar graph you saw on the previous slide, of the states nationwide that are in these different phases. But we wanted to get a sense from everyone who's on the call what phases you all are in. And so I'm going to open a poll, and everyone bear with me because I just learned how to do this. If it doesn't go as well as planned, I apologize. But I'm going to open this poll and really hear from you all at what phase you are. And we can really get a sense of where we want to take this from. So hopefully you all can see the poll. I see everyone's participating, so we'll give a few more minutes just to kind of get an idea where everyone's at. Okay, I'm going to go ahead and close that poll. And in 1 second, I'll be able to show you all where everyone on the call is at. Okay, so hopefully you all can see that. It looks like the vast majority are in phase 1, so about 7 of the people that responded, and also a good number in phase 5. So we have a nice even spread here, which is good. So we have some right at the beginning, ready to develop their program, getting started, and a few of the experts who have been here and have done this for a little while. So that's great. We can have a good discussion here going a little bit later. And with that, with the idea of where everyone is, I'm going to let Kate take over and really talk about the background of pediatric readiness programs and specifically the Facility Recognition Collaborative, where we kind of all began.
Great, thanks so much, Meredith. And for those of you on the call who just listened to those phases that Meredith went through, and those of you who participated in the Facility Recognition Collaborative, you can see that those pretty well align. The only difference is that we've set apart the piloting piece with the formal recognition and program in place piece. But otherwise, they really do align with the Facility Recognition Collaborative, and just wanted to give a little bit of background on that collaborative for those of you who may not have been part of it, and just as a recap for those of you who were. So if you could go to the next slide, please, Meredith. So what we do know is that for those states that have a pediatric medical recognition program in place, we know there is variability in terms of the number of emergency departments that are actually formally recognized through that program. And in fact, there are some states that has as few as maybe 15% of the emergency departments recognized, and others that have as much as 100% recognized. And those states typically are those with mandatory programs. I know that New Jersey and Delaware are up close to that 100% mark. And so they've certainly impacted the outcomes of this. But a number of us work together to look at how does having a pediatric medical recognition program in your state impact your overall state mean pediatric readiness score. And so despite that variability in participation across those states, what we can see is of all those sites that are actually participating in the recognition program, they do bump up the state mean. So in this case, the mean state average for the average for pediatric readiness in those participating states is 74.8 compared to those states that don't have it. So even just starting the process of recognition seems to have an impact because it probably increases awareness, and we can get into all kinds of speculation about how that really impacts overall care in the state. But it's really important to at least know that we're beginning to see that just having a program really can make a difference in terms of overall pediatric readiness across the state. So if you'll go to the next slide, Meredith. Great. What we also know is from the work that we did in California many years ago, that of course those EDs that are recognized have much higher pediatric readiness scores. This makes sense because they're required to maintain certain levels of readiness, and that those levels of readiness are of course based on, at this point in time of this paper, was the 2009 guidelines. And so, of course, we're seeing this significant difference of pediatric readiness scores on average at 89.6 versus non-verified EDs at 65.5. So it does make a difference overall. And then most recently, we're so grateful to Stephanie Ames, Jeremy Kahn, and the group who recently published a manuscript of the impact of this readiness on pediatric mortality rates. And we see that for those EDs that maintain high levels of pediatric readiness, so really in that 89 to 100, that it decreases the odds ratio of morbidity and mortality. And in fact, the mortality rates are much lower with an adjusted odds ratio of 0.25. meaning that 1 in 4 children are, excuse me, 3/4 of those children are less likely to die if they have a critical illness in those high PEDS ready locations. And so this is really important to keep in mind, is that it can really have a significant impact on morbidity and mortality for children by maintaining pediatric readiness. And I think this really forms the basis for that push to really develop pediatric medical recognition programs. When we kicked off the FRC back in 2016, we didn't have this strong of mortality data. And I think this is a really important talking point that we begin to add into our education and garnering stakeholder support across the state, is that pediatric readiness isn't just about having structure and bells and whistles, but it really does impact outcomes for children. So it's really critical that we're communicating that to our stakeholder groups. If you could go to the next slide, please, Meredith. We've also talked a lot about trauma and the impact of trauma centers on pediatric readiness. We had an initial paper that came out about U.S. trauma centers, and in this one, we are looking more specifically at level 1 and 2 trauma centers versus level 3, 4, and non-trauma centers. And on the surface, it appeared that level 1 and 2 trauma centers were absolutely more pediatric ready than level 3, 4, and non-trauma centers. But what we also began to realize was that most of these level 1 and 2 trauma centers actually participated in a statewide pediatric medical recognition program. And so when we actually controlled for that with respect to these numbers, we shockingly found that there really was no difference in overall pediatric readiness between level 1, 2 trauma centers and non-trauma centers. And I think this really speaks to the lack of alignment between the trauma priorities and the medical priorities within a given facility, and the need to improve communication around that. So for those of you that might be working with, your state trauma verification programs or your trauma systems within your state, this is a really important talking point because it demonstrates that just being a trauma center, even a high-level trauma center, doesn't really translate to pediatric readiness. If you'll go to the next slide, please, Meredith. And this was a more formal paper where we actually looked at, well, so what is the difference between these high-level trauma centers and EDAPs? What are they missing? What are the big gaps? Because when we looked at, all children's hospitals, we know that their pediatric readiness score on average is 96.7 or, around there. EDAPs, 87, and then all trauma centers, 69. And there's really an opportunity for improvement here. And so we did a comparison between level 1 trauma centers and EDAPs that were in the National PEDS Ready Assessment database. And you can see the results on some of those core domains that are listed in the pediatric readiness guidelines. And what you'll notice is that some of the core gaps of those high level 1 trauma centers is that many of them don't have a pediatric emergency care coordinator. Many of them don't have interfacility transfer agreements for pediatric medical patients in need of higher resourced centers. Many don't have a true quality improvement process in place to look at the delivery of care for pediatric medical patients. And so they might be doing this for their trauma patients, but when it comes to the medical side, it just wasn't translating. And then in addition, when we look at disaster planning, even at these level 1 trauma centers, pediatric patients were often not included in that. And so this really helps us to tease out what is the difference between what a level 1 trauma center has and what an EDAP facility has. So go to the next slide, please, Meredith. So the overall mission of the Pediatric Facility Recognition Collaborative was that we know all children deserve timely access to EDs. that are ready, you know, to take care of these critically ill and injured children. And so our aim was that by the end of the collaborative in December of 2017, that we would increase by 50% the number of states that have developed and improved an implementation plan based on, at that time, it was the 2009 guidelines for care of children. Of course, now we have the more updated guidelines from 2018. And if you'll go to the next slide, please, Meredith. So I'll turn it back to you, Meredith, to talk about how we're transitioning this to the community of practice.
Yeah, excellent. Thanks, Kate. Are there any questions about facility recognition or what it was, or any questions for Kate on pediatric readiness, anything? Okay. And if you want to learn more about what the Facility Recognition Collaborative was and read the white paper that Kate, Chris, and Diana put together that really outlines their conclusions and the findings from the Facility Recognition Collaborative, I'm going to put in the chat box right now the link to the webpage, and then you can all go there. You can read the white paper, and there's also some other resources there that I'll show you at the end of the call where you can go. So now we are transitioning from the collaborative to the Pediatric Medical Recognition Community of Practice. And so what this really is maybe a less intensive version of the collaborative. So we want to continue the support of ongoing activities in your state, of developing a program, whatever resources, experts we can offer you as a part of EIAC and HRSA together. We really want to promote sharing of best practices among the states and really help you troubleshoot problems, help you troubleshoot challenges. We're going to have these calls quarterly. We want to hear from more of the states. Today we're just going to hear from 2 of y'all, but we would like to hear from more in the upcoming sessions and really turn this over so that it's a community and really define that as you all helping each other with us here supporting you. So just a few culture and ground rules we wanted to establish, that we are here to support each other, and so there will be no shaming. And the more we share, the better we do. So any resources, anything you can share that would be useful, templates, example protocols, anything, I'm happy to send them to me and I can get them up on the webpage. We'll also talk about maybe establishing a Yammer page, which I'll show you at the end of this call, that could really hopefully enhance some collaboration. The results and activities discussed here will not be used to judge the effectiveness of the SC program in your state. Also, attendance and participation is voluntary, but we strongly encourage engagement during this webinar and all the upcoming webinars so that it can really help support collaboration, and we can now get to the end of this performance measure. So there's been a few activities to date beyond the FRC collaborative. And there was a call back in April, and some of you I know were on it. It was open to those who participated in the Facility Recognition Collaborative or were recognized by HRSA as having a facility recognition program, which means having a score of 5 for EMSC Performance Measure 4. During that call, and if you want to, it was a great call. There's a lot of information. The recorded link is up here. You can listen to it. It's about an hour-and-a-half call, but about 10 states gave updates on their programs, and there was a lot of sharing of enablers. Some of the key ones I pulled out from the call was that having an active and engaged advisory committee and collaborating with partner organizations in your state. So your local ENA chapter was a big one, working with them to help get your programs together. Some of the barriers, size of the state, I know Fatima talked about us here in Texas and how, we have 700 hospitals and it's a huge undertaking. Also getting engagement from the hospitals, personnel, time, money, and a big need for templates and example policies and processes, which hopefully maybe through this community of practice, we can start to put the library of those together for everyone to use. We also have presented about the FRC at the All-Grantee meeting in DC a few weeks ago and had a really great room full discussion going on there in our breakout sessions. And some of the challenges we pulled out is that some of the verbiage around recognition is tough still in some states due to the political climate. So Many are using endorsement or a hospital preparedness program. Also, facility, when it was the Facility Recognition Collaborative, we've kind of combated this by now changing it to pediatric medical recognition. But for me, the focus is just the ED and not the facility in total. And so really our message is use what works for your political climate. And then another challenge was sustainability, so funding and personnel and time to really evaluate these facilities and come back in the 3 years to make sure that they're still up to speed. So general enablers we're talking about, the 2020 NPRP assessment is coming out in June. And to kind of use that to motivate hospitals to really get up to speed with getting ready for PEDS Ready. For those of you that participated in the PRQC, to really use these relationships with these hospitals as a launch pad for the program and even as a way to sustain the progress made with PRQC. And then a few comments just during our discussion session is that both the ACS Orange Book and ASPR language now include language about pediatrics. And so this can really help you motivate some of these hospitals to get engaged with pediatric readiness. And with that, I guess I will turn it over to Indiana and Connecticut. I think we have Indiana up first. So if Margot, you want to talk a little bit about your program in your state, feel free to take it away.
Yes, thanks, Meredith. Hello, I am Margot Knesselkamp. I'm the program manager for Indiana EMSC. I'll begin with team introductions on the left-hand side of the slide. You'll see Dr. Elizabeth Weinstein. She is the IEMSC program director and has been for the last 10 years. She is an emergency medicine physician in both adults and pediatrics. Dr. Greg Ferris is the co-chair for the Facility Recognition Committee. Dr. Ferris is a pediatric emergency medicine physician. And Dawn Sullivan Michelle Wright. She is the pediatric chair for the state chapter of the Indiana Emergency Nurse Association. IEMSC is housed at the School of Medicine located at Indiana University. Indiana has 133 emergency departments with several micro hospitals to open shortly in the urban Indianapolis area. The current state of Indiana's program is a 2-tier voluntary program. There's no cost to the institution applying. You can either apply to be pediatric ready or pediatric advanced. Our committee met monthly for nearly 2 years to design Indiana's program during the Facility Recognition Collaborative. The committee consisted of the Emergency Nurse Association reps, the Indiana State Trauma and Injury Prevention, as well as the Hospital Preparedness Division at the State Department of Health, the Indiana Rural Health Association, the Indiana Hospital Association, the Indiana chapter of AAP, and the Indiana chapter of ASEP, Patient Safety Coalition, and Pediatric Emergency Medicine Physicians. We did not build a critical care tier at this time, but we'll look to add that later. Indiana EMSC is the host institution with support of an FTE from Hospital Preparedness Division within the State Department of Health. The applications launched in November 2018 post our consensus conference that was held in November 2017 at the Department of Health. We made sure that we had hospitals represented as well as our committee. The agenda for the day was a 4-hour meeting. We sent materials in advance to attendees, the overview of pediatric readiness, other states who have it, the process over the last 18 months and how we got there, and then during the meeting, we went through the criteria domain by domain for pediatric ready and pediatric advanced. Highlights from the consensus conference is that there was more demand than we feel we were ready to meet, and we would need to be mindful of our efficiency and resources moving forward. The goal for year 1 is for Indiana to pilot 5 hospitals. To date, 15 hospitals have requested an application. The application packet consists of an EMSC welcome letter, instructions for pediatric readiness application, the criteria, the application for pediatric ready, as well as the application for pediatric advanced, site surveyor guidelines, so what that would look like when we come and do our site visits, and then pediatric equipment checklist. We decided not to have the applications just yet on our website. This has proven to be successful because I check in with the hospitals monthly or every to determine who is close to submitting. Our team then does a monthly check-in internally, either on the phone or in person, with the Department of Health to share who is applying and where they are in the process so that we can anticipate demand. Next slide, please, Meredith. Accomplishments since January 2018 is we've developed our facility recognition program criteria for 2 tiers. We've held a consensus conference in November of 2017. We continue to do presentations to Indiana Trauma Care Committee, our Patient Safety Coalition. We hope to get into the Indiana Rural Health Association's annual conference that will be occurring in June, present at state chapter E&A meetings, as well as the Healthcare Coalition District. Applications did launch in December of 2018, and as of this morning, we have received 2 applications. 2 items we are currently working on is we're working with REDCap in the School of Medicine to be able to offer the application in the future online. We did go back to the 2 hospitals that did apply by paper. We asked them to go ahead and fill out the online application. We tested internally and we tested externally with one of our hospitals that is recognized by Illinois' EMSC program. And this is beneficial to us because the 2 hospitals that we will be needing to go in and do the on-site verification happen to be children's hospitals, one in which Dr. Elizabeth Weinstein is affiliated with, and the other is a direct competitor. So we're going to be able to send all that information electronically to the site reviewers that we're going to have come in and do the site visit here this November. This does, however, make it difficult for us to pilot, but we are moving forward. 13 other hospitals have requested the application. 1 is very close to submitting, and 3 others are completing their gap analysis and assigning parts of the criteria to others in their team. There has been lots of momentum now. In June, Dr. Weinstein presented to the biannual Healthcare Coalition Conference, Indiana's Facility Recognition Program, and at the end of her presentation had a slide regarding the Pediatric Surge Annex requirements. The template was released from ASPR just the day before, and it specifically listed on the template HCC should promote members planning for pediatric medical emergencies and foster relationships and initiatives with emergency departments that are able to stabilize and or manage pediatric medical emergencies, which was a great plug for the districts to reach out to EMSC to increase their pediatric readiness efforts. 2 weeks ago, Dr. Weinstein, along with Dr. Roxana Lafort, presented to the Indiana Healthcare Emergency Preparedness Symposium, or IHEPS, an excellent presentation. It was the fundamentals of children in disaster: keep children alive, keep children safe, and find their parents. I had a booth set up, and I received several questions about Indiana's Facility Recognition Program and requests to come speak at the districts to share the program and how Healthcare Coalition districts will reach the Pediatric Surge Annex requirement. So each district, we have 10 districts here in Indiana, is designing their own Pediatric Surge Annex, and the State Health Department, where HPP is housed, has invited Dr. Weinstein to serve on the state committee. Then just this last week, I attended the Indiana Emergency Response Conference and had an opportunity again to speak with attendees about our current program and EMSC priorities. Enablers or barriers, enablers, stakeholders, we rely heavily on them and utilize their conference or events as a venue to communicate the program. A few barriers is the financial concerns and political landscape, as well as job changes. The Indiana State Department of Health has agreed to offer support with an FTE, which we did have for 2 months the summer of 2018, but he then quit. But they have offered to help us moving forward until there is more momentum, and then they will fill that FTE position. Strategies taken to overcome barriers or description of assistance needed. Again, our partnership with the State Department of Health, again, offering staff support. And the advice that I would share with other states who are starting a recognition program is partnering with those who have done this before. When we were reviewing criteria, we looked heavily at Illinois' program because we felt that there was of what they had and what our 3 hospitals in Indiana already had with our recognition with them. Utilize the current environment, mention the pediatric surge annex, encourage hospitals to obtain an application packet and begin their gap analysis, to utilize EMSC as a resource to obtain their facility recognition, share resource documents and toolkits, and then offer to attend events in the arena that you can get in front of to share what's currently going on with your program. Thank you, and please reach out for any questions as you begin your process.
Thank you, Margo. That was a really good overview of your program. Any questions for Margo? You're welcome to jump in or use the chat box if anything you want to know from her. Okay, well, with that, I guess we will move on to Connecticut and let Tom kind of talk about your program. Are you there, Tom?
Can you put him on off mute?
Oh, you should be off mute.
Hi, guys. So can you hear me? It's Mark Auer back.
Oh, yeah,
We can hear you, Mark.
Excellent. Thank you so much. So thanks so much for the opportunity to share today. So I'm excited to follow on the footsteps of some really great work done in Indiana and some good friends and collaborators there. Tom was nice enough to present this work on our last call. However, we've had some changes in our team. So Tom was actually not a core member of the team at the time of the development and implementation of the collaborative. So he had asked for me to sort of join today. So I'm Mark Auerbach, one of the medical directors of Connecticut EMSC, and just wanted to share sort of the story of where we are today and sort of where we've come from. So in Connecticut, we currently have 34 of our 36 hospitals participating in a pilot voluntary recognition program. This was launched in January 1st, 2018, and it was voluntary. And after discussion and meeting with many of our stakeholders on numerous occasions, we really felt that the political climate and the emergency departments and hospitals in Connecticut wanted to take a voluntary approach and start off with a pilot program and really use that pilot program as a stepping stone or a first step in this, hopefully eventual phase of having a more sustainable and ongoing program. So the concept here was really starting off with the floor, and then from the feedback from our stakeholders that we would raise that floor and elevate that floor each year, but that each year there would be an opportunity to achieve different levels of recognition. So for the first phase, which was our pilot year, and again, trying to make this as straightforward and simple as possible to garner support and engagement and to learn from each other and with each other, we started out with off-site completion of the documentation. So really the requirement was a letter of support from a C-suite member of the institution, completion of the Pediatric Readiness Survey between January 1st of 2018 and December 31st of 2019. Completion of documentation that designated a PEC, so that executive letter needed to state whom either a nurse and or physician PEC was for that institution, and participation in the statewide EMSC program. We had the benefit of having a state that both children's hospitals, subsequent to the initial facility recognition collaborative, partnered on a statewide effort for MPQRC. So that overlap with this, that's the National Pediatric Readiness Quality Collaborative, and we are able to leverage this process of the initial facility recognition to really find those overachievers and people that were wanting to do a bit more and get them engaged in MPQRC. So really our efforts during the collaborative were focused on creating a community of individuals across various stakeholder organizations from the ones that were listed. So we engaged AAP, ENA, ASEP, some of the school-based organizations, the hospital association in the state, and senior leadership at many of the larger health systems, as well as the two children's hospitals, to come to consensus on how we were going and again decided on this voluntary approach with sort of a moving the mark, so to speak, with each year of the program. So the levels of the first program as listed there were really the opportunity for any site to be recognized for participating, and we went back and forth a lot on what this term should be, but really it was pediatric engaged, and we felt this was important so that they could begin this journey and not necessarily feel like unless they were at a certain level they couldn't come to the table or participate. And we felt that from hearing from a lot of our hospitals that had improved that they wanted to help the other hospitals and felt that this would help to facilitate statewide movement of the needle. So really, to be considered engaged, you could have any score on the readiness survey between 0 and 70 with this designated pediatric champion. To be considered pediatric ready, you needed to exceed our state mean and the national mean of 70%. So you needed to be meeting that engaged criteria of having a pediatric champion, that letter from the C-suite, as well as a over 70% score on your pediatric readiness survey and gap analysis was received. And then the highest level was pediatric innovator. And this was really a debate as to whether or not we should go with only one level, 5 levels, 3 levels, and really we came across this idea of trying to have the focus being that anyone could come to the table, and that's where we came up with engaged. Ready would be considered sites that hopefully made that first step, but that innovator would bring people together into a statewide community of practice where if they were over 80%, they needed to be willing to share a program or resource with other EDs and departments in the state so that they could advance their pediatric readiness. So all of our EDs got access to these community of practice resources by participating. This included educational modules that were available actually through a partnership with Baylor, policies, procedures, quality improvement modules, and safety practices, as well as things like cognitive aids and the use of apps that we supported through the state. Our current state going into 2019, as is mentioned there, would be to move this to an online application that would hopefully facilitate ongoing work and efforts that would take away the need for paper and pencil. And we also recognize the need for what I would refer to as an alternate, that we recognize in many of these institutions, there was a tremendous amount of turnover. There might even be one hospital system acquiring or merging with another hospital system. So having both a alternate individual listed for the executive level contact as well as an alternate for the pediatric emergency care coordinator or PEC. Next slide. So our accomplishments since 2018, as I mentioned, really I think what we've been most proud of is engagement in this community of practice within our state. So we've leveraged the technology called ECHO, where we have a monthly community of practice where individuals can meet and have an expert providing a didactic presentation that's approximately 10 to 15 minutes, followed by cases that are actually presented by our community hospital and a facilitated discussion where we learn from and with each other, as well as from the Children's Hospital or Academic Medical Center content expert. We have provided annual simulation-based assessments that augment the pediatric readiness assessment at the hospitals that are participating. We provide access to the modules, the cognitive aids, and opportunities for things such as the MPQRC. Again, our future plans would be that online assessment as well as raising that bar, so moving more towards an in-person validation with a peer-to-peer approach, as was mentioned by Margot, where with 2 large health systems in the state, we can ensure that one health system is evaluating another health system as opposed to evaluating itself. And our goal in the upcoming year with simulation and in-person validations is to continue to identify target areas that are cross-cutting in the state, develop action plans, build those relationships. We did provide little things in addition to the letter to the CEO and C-suite as far as recognition. We did some press events, and we actually provided a plaque that can be put up in the ED to recognize these programs in that period of time, and that could be at the engaged, ready, or innovator level. The most significant enablers and barriers really had to do with turnover, and that was both on our team as well as at the frontline and executive level of the community hospitals and children's hospitals. We also realized demands. During this time period, the PEC collaborative for pre-hospital care ended up taking a lot of our time and resources. So we are in a phase that we need to reboot, I guess you could say, and bring this back to life after we've completed all the paperwork, have people engaged. We're getting to the point where we need to start thinking about what the second step is going to be, in terms of having that ladder that we would like to create, but move the baseline step of that each year, so that hopefully in the next iteration, engaged would be a score of 70, ready would be the innovator status, and innovator would be something beyond that. We've tried to improve our record keeping. We fortunately have an administrator, Christina Carson, and some others that have helped quite a bit with that, and really tried to use things like constant contact and other methodologies that I was not as familiar with, and increase the frequency of interactions and site visits. Our advice would be flexible and start somewhere. I think one of the challenges that we had in the state was trying to come to consensus on a program that I think we will be at, and I hope we'll be at in 5 years. But many of us wanted to start there and really have a progression very fast. And I think that this recognition that we wanted everyone to come to the table and agree, in organizations like ASEP that perhaps were more hesitant, we wanted to make sure that this was considered something that they felt that they were a part of, and not something that they were external to. And really, I want to thank Kate and Cassidy and Charles and many others who were involved in leading the collaborative, because I think that we learned a tremendous amount from the other states as well as the collaborative leaders, and that allowed us to achieve the success that we've had. So I see a couple questions here. I get excited about this stuff and like to talk. I don't know if there's another slide, is there?
No, I don't think so, just two.
Okay.
No, just those two more.
Okay. So I'll take these questions. So there was a question from T about, could you share a little more about one system evaluating another system? So thank you, T, for that. So at least in our state, just to be very specific with our 36 hospitals, when I first arrived in Connecticut 10 years ago, there were probably about 30 different organizations, including the Catholic Health System, Yale New Haven Health System, and the Hartford Healthcare System. Now I would say we're down to about 6. So Hartford Healthcare System and Yale New Haven Health System have acquired probably 20 plus of those hospitals. And this has created some opportunities, but also some challenges. And I think we, as an organization that have stakeholders from within those large healthcare systems, want to make sure that we are not evaluating ourselves and just sort of blowing our own horn, so to speak. So our hope in the next iteration would be from the work that was done by Evelyn Lyons in Illinois. I think leveraging that to say that this should be an external reviewer and evaluator, and coming up with processes similar to what ACS has with the American College of Surgeons, that you can say, you know what, there's not a conflict of interest here. This is truly an external review. Within New England, we have had some discussions with our surrounding states, such as Rhode Island and Massachusetts and others, that we have this pipe dream for the future, that if we had a similar program, we may be able to even cross state lines.
Great, Mark, thank you. I think Kate had a question too. Sorry, do you have any advice for others regarding starting simulation or on-site education for those with less expertise in SIM?
Yes, so I think we frame this, and when people hear me talk about it, they frame it a lot as simulation, and I would frame it as collaboration with one opportunity as a methodology or instructional technique that seems to be sexy and exciting to many community hospitals, being simulation. There is something called the SimBox, which we've created in New England, and I'm happy to share the link on that in a moment. But that's, again, starting, as T said, start somewhere, and that's really a blow-up doll that we have some support through ASEP from, that we can send out to people that has a scripted pediatric readiness type approach to the interaction. And we've found that building a relationship by going in and saying, hey, we're EMSC, you need to do better at pediatrics, you need to get more pediatric ready, was where we started. And we've tried to shift from, hey, we're EMSC, let's figure where you're at, and let's figure out how we can best help you to begin this journey. And if you're an EMSC readiness score of 30 or 80, that's probably going to be a very different conversation. But we've really found that low cost, low resource lifts that are value added most surprising one to me in the past 3 years has been our vital signs cards. Those are approximately 22 cents each, and no matter where I go to in the state, I feel like I can find one of those sitting around in the ED, and people see that as a real change, making it easy for them to do their job well. And we had started out with trying to supply Broslow tapes and recognized that those walked, they were expensive. So I think this concept of simplicity and trying to hear from the frontline providers in these community hospitals what we can do to make it easy for them to get engaged in this process.
Thanks for that, Mark. I think it's so great because rather than providing on-site visits and actually going in and providing education and resources, it really helps to garner support and engagement in the whole process. And so you guys have a great model there. Thanks for sharing that.
That was great. Any more questions?
There was a question from Margot. So she mentioned, did we slow with the ASPR grant? I think we slowed with the PEC collaborative more so than the ASPR grant, and I don't think we slowed. I think we just became pulled in a number of different directions. So as we've tried to take some of this work and the lessons learned in the hospital-based setting and bring it to the pre-hospital setting, our state being involved in that hospital pre-hospital collaborative after we were sort of hitting the ground and just in stride with the hospital-based recognition program, just started to consume more of our time.
Thanks. Any other questions for Mark in Connecticut? You guys have done amazing work, a lot of work. It's great. I'd be interested to learn more about your echo technology and how maybe we could leverage that. So that is great. Thank you. So with that, I was just going to show you all some available resources that I put on the webpage. This is the link here. I've also put it in the chat box. If you go here, and this is what it will look like, you'll hear the link, the WebEx meeting link is going to stay the same for all of our quarterly calls. So it'll be here on the homepage too. Here's the link again up top. A good place to start is the FRC white paper. That's found right here on the homepage. If you go to the FRC, this tab right here, you can click on this. The white paper is right there. You can learn about the history of FRC, what came out of that program. I also have collected best practices. So if you click here, a lot of the best practices and things that were developed during the FRC collaborative, such as the minimum criteria for a pediatric medical recognition program, which you see here on the right-hand side, I've previewed for you, as well as different phases of implementation and other important documents you can find out here under best practices, as well as state-based resources that have been shared with us. And Renee, I know you said that this one from Alaska is your old version, so if you want to send me the new one, and I will get it posted to the webpage. But here under best practices, there's resources from established recognition programs. And so this is a preview here. You can see there's different fact sheets from different programs, different resources you can find here. If you have more resources, please send them to me, and I'd be happy to post them up here. Even if you don't have a established program yet, anything that you would find useful, please share with us. So with that, we had started this collaboration tool called Microsoft Yammer with the PRQC collaborative. And what it basically is a Facebook for professionals. And so it's just for people participating in the collaborative or this community. Similar, you can do a post. You can see my post here sharing the most recent white paper. You can like it, reply it, share it. You can add hashtags. You can pin documents. So we could put templates here, private message. You can see here in the PRQC, we have 361 members. You can share a file, post an update, a question, a poll, an announcement. So we really want this community practice to be focused on collaboration. So, and I'm going to open this poll here. Would you all find this useful? I'm happy to put it together for this community of practice and really manage it if you all think you would find it useful. And I went ahead and opened the poll now if you'd like to, and I'll let this just run for about 5 minutes or so. In the meantime, any other questions or comments? Okay, we'll just give it a few more minutes, let everyone have a chance With the PRQC, it's been used with somewhat useful, I think. There's a few people on our PRQC page that are very active and a lot that haven't used it. The one downside is, we looked through a lot of collaboration tools and how we could really enhance collaboration with PRQC. And there's certain things you run into with like hospital IT programs, blocking most of the more popular ones like Slack, or even a Facebook group like our fan members use. And so this one, as part of Microsoft Office 365, most have access to it. The only downside is you can't use a Gmail or a Yahoo email address. You have to use an institutional email address, which has been a trip point, I think, for some people, but not a whole lot in using this tool. Let's see here. Okay, I'm going to give everyone about another minute or so. Let's see here. I'll show results. So this maybe about, 10 people would be interested. But 18 or so answered, 14 or so answered, and 4 said no. So I will go ahead and put this together, and then we could still see maybe in the next few weeks an invite for me to join this page. If you have any trouble, feel free to always email me. I think my last slide here is, my email address is right there at the top, and I can put this in the chat box as well. Hopefully you have it somewhere if I'm getting the meeting invites from me. So any other questions or comments? We'd love to hear what you would like from us for this throughout this collaborative. How can we better support you all? What resources, anything from us would you like to see? I see, Catherine. I'm sorry, I didn't mean to close it so fast. Program renewal development, that's a good one, Renee. I think that would be interesting to talk about too. Any other questions, comments? All right, well, with that, I guess we can go ahead and close. Thank you all for joining us. Kate just said, thank you all for joining the call today. Like I said, they'll be quarterly, so our next one won't be until January.
Hi, Meredith. This is T. I do see 2 questions. You're probably not seeing it on your end yet. One of them was for Renee asking about program renewal development and funding opportunities for sustaining the program. I think they're looking for resources and ideas in those areas.
Okay, yeah, great. I think we can work on developing some resources in that area and maybe make it a topic for one of our next calls.
Yes. Great job. Great job. Thank you.
Great, guys. All right. Y'all have my email address. Feel free to email me anytime. Thank you all.
Thank you.